All right, good morning, everybody. So on behalf of Screen NJ and Rutgers Cancer Institute, welcome to Community Cares and Project Echo, the Survivorship series. So today we're going to do a presentation on surviving honestly, supporting transgender people. Evelyn, are we recording? I can't see if I think I see it now.
Yes, we are.
Thank you. Hmm. So this is just a quick disclaimer that the information contained in this presentation is not substitute for medical consultation, and a physician should always be consulted for any health problem or medical condition. So today's agenda, we're going to do a Project Echo series overview, introductions, the actual presentation, some case studies, and at the end we can do questions and answers. So a little bit about Project Echo. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The Echo model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. So for more information on Project Echo, you can visit echo.unm.edu. So today we're going to do introductions, and it's going to be a little bit different than our normal echoes because today's presenter has chosen to stay anonymous due to the increasingly hostile climate towards transgender individuals, the promotion of equity and diversity, and the field of public health. And while they do not feel currently comfortable disclosing more details, I can say that they have a master's of public health and have worked with the trans community for almost a decade in various capacities, as well as having lived experience as a trans person. They remain dedicated to the cause of health equity and are humbled to have the opportunity to share their knowledge with you all today. So now I will pass it to our presenter.
All right. Hi, everyone. As Sarah said, I apologize for the slightly unusual mode of presenting today. I'm sure that we are all aware, as we are all seeming from the chat to be in the field of public health in one way or another, that these are unusual times that we're living and working in, but I still think it's incredibly important that we get this information out there. So to start, next slide. Again, this is just going over what Sarah said in the introduction. I have an MPH, I've lived as a trans person, and I've spent the last 8 years working with trans health and adjacent topics. Next slide. So to start, I want to make sure that we are all on the same page, regardless of anyone's personal opinions, any policy changes, restrictions, etc. Trans people exist, and trans people need medical care, not just gender-affirming care. They get a lot of the same care as everyone else, but getting it and providing it isn't always that simple. So going into this, again, this is the baseline that we all have to be at the same understanding for. Next slide. Trans people are also not new. This is a brief timeline on the modern medicalization of transness. The first vaginoplasty on a trans woman was actually done in Germany in 1931, 12 years after a German scientist named Magnus Hirschfeld opened the Institute of Sexual Science. These two photos in the top right now, they are extremely famous photos of Nazi book burnings. And what most people don't realize is that this took place at the Institute of Sexual Science, destroying the bulk of existing research on gender and sexual minorities in Germany. Not going to spend too long on this timeline, but the trans community is not new, and neither are the attacks on our well-being, safety, and healthcare. Next slide. As we go through this, I want us to keep two questions in mind. One, what does survivorship look like when your care team doesn't see you for who you are, when they don't see or respect all of you? And what does surviving cancer mean if the person you fought to be and worked to discover doesn't survive? Next slide. I'm going to briefly go over some basics about gender-affirming care and terminology, especially aspects that can relate to cancer care. Trans men are people who were assigned female at birth and who live as men, and trans women were assigned male at birth and live as women. Intersex individuals can also identify as trans, hence the generally assigned male or female at birth. And non-binary people can be assigned male or female at birth and transition in the corresponding way. So a non-binary person assigned female at birth and transitioning to non-binary could be considered transmasculine. Trans people may do any or all of the medical interventions listed on this slide, or they may choose to do none of them, or they may want to do some or all of them and not have access to them. Transition is a very personal choice and one that can have an impact on certain cancer risks, but no impact on someone's value as a person. There are other forms of gender affirming care, including therapy, voice training, electrolysis, hair transplants, and more. But again, we're mainly going to be focusing on forms that have the largest impact on cancer risk. So, the most well known probably being hormones, being that transmasculine individuals may take testosterone, transfeminine individuals may take estrogen and/or progesterone. Transmasculine individuals may get hysterectomies, oophorectomies, mastectomies as part of top surgery. Trans women may get breast implants, vaginoplasty, which can include orchiectomy, etc. Next slide. So, why does considering transness in the context of cancer matter? I'm going to go in depth about some of these topics during the case study portion, but overall, we know that trans people have some unique challenges when it comes to healthcare. According to the 2022, according to the 2022, 20, yes, I'm saying that correctly. I know how to say numbers. The United States Transgender Survey, a survey of over 93,000 trans people nationwide. Nearly 1 in 4 trans folks delayed or avoided care in the previous year due to fear of mistreatment, which isn't an unfounded fear. 47% of respondents reported at least one negative experience with a healthcare provider in the last year. Most common was misgendering or dead naming at 37%, meaning someone was called by their name given at birth and not their preferred name, or the incorrect pronouns. That was 37% again. 18% had to teach their providers about their own healthcare and identity in order to access appropriate care. And 11% were asked invasive questions that were unrelated to their care about their gender identity, etc. Smaller amounts of patients also reported things like verbal harassment, physical abuse, and unwanted sexual contact in healthcare settings. Beyond that, patients and providers alike may not know what kinds of screenings patients need. Patients don't know what they don't know, and providers don't know what they don't know and don't know what they haven't been trained on necessarily. They don't always recognize gaps in their knowledge, just like patients don't. So, patients need to be able to rely on their providers for accurate information. They should be able to trust that the information they're getting is complete and accurate to the best of the ability of the fields at the time. They shouldn't have to have the extra burden of seeking out a screening schedule that is given to cisgender individuals by default, cisgender meaning not transgender, especially because they may not know to. Patients don't know what they don't know. I emphasize that again and again because it's something that we tend to overlook that, oh, a patient will ask for this if they want this. Patient will ask for this if they need this. Next, patients may feel uncomfortable or be unable to get gender-associated cancer screenings and care. Folks may have heard stories of the discomfort of cisgender men who get diagnosed with breast cancer being in predominantly female spaces with support groups focused around women's empowerment. There's no space for them. If you're someone everyone sees as a man and you know yourself that you are a man, you're going to feel out of place at a women's clinic. Additionally, patients have limited time, money, energy, etc., and they're going to prioritize the care that is most important to them. This underlines the need for a patient-centered medical home model where as much care can be done under one roof and at one time as possible. We can't determine a patient's priorities for them. They're going to have their own hierarchy of needs, and we need to work with them to prioritize meeting those needs to ensure the best care possible. I don't like using terms like non-compliant because those tend to assume that a patient simply does not want to engage in their own care, when oftentimes they're simply not able to because of limited capacity and resources. We know that gender affirming care is life-saving healthcare, so it shouldn't be surprising that for some trans people, that's going to be their absolute baseline health need before anything else can be fulfilled. And finally, insurance and monetary barriers. Insurance may cause issues when someone who is legally male tries to get a pap smear, for example. Not to mention that 13% of people in that survey had no insurance at all. Even with insurance, cost can be prohibitive, with 28% of respondents avoiding care due to cost, both insured and uninsured patients. Individuals also may not be aware of the currently standing ACA mandates to cover preventative care. Trans people are also more likely to be on Medicaid and have lower socioeconomic status than cisgender counterparts of similar identities. This is the aspect of care that we have the least control over, so we're largely going to focus on mitigating the other aspects that can serve as barriers to effective care for trans people from screening to remission, but it is important background knowledge to keep in mind and to think about ways that we can mitigate these structural barriers as well. Next slide. So, trans broken arm syndrome is a colloquial term for when providers assume that something completely unrelated to someone's gender identity must be caused by their transition related medical care, such as if someone broke their arm falling out of a tree and the doctor told them, well, it's obviously because you're taking those hormones. It's sort of like when overweight or obese patients are told they just need to lose weight no matter what they go in for. Weight and gender affirming medical care are part of a patient that should be taken into consideration, but rarely is it ever the only aspect of someone that should be considered. The more proper term for trans broken arm syndrome that has been proposed is gender related medical misattribution and invasive questioning. Invasive questioning part is that not every aspect of someone needs to be disclosed for appropriate care. You don't necessarily need to know if your patient who is there for a lung cancer screening is planning to get bottom surgery. However, affirming care is part of a patient, not just for the purposes of treating them with respect, but because depending on the health issue at hand, gender affirming care can have an impact. While literature is limited, one example is that masculinizing gender affirming hormone therapy may decrease the risk of estrogen responsive breast cancers, but the potential impact, once diagnosed, is even more unclear. For this reason, many oncologists recommend stopping testosterone for trans men diagnosed with estrogen responsive breast cancer, a step not taken for cisgender men with breast cancer. They're not put on medication to stop their natural testosterone production. It also may not align with a patient's priorities for their care. When we make decisions for patients rather than with them, we're risking a loss of contact and inadequate adherence to care. And this is especially notable for the trans community, a community from which trust and autonomy are often withheld in healthcare settings. Next slide. What you see on the screen are a couple of quotes from legal expert and bioethicist Florence Ashley from their piece regarding how dehumanizing the practice of requiring therapy letters for gender affirming hormone therapy is. I'm gonna get some water. If you're unaware, many providers and insurance companies require trans people to get a letter stating that they really are trans and of sound mind before getting hormones or surgery. For some surgeries, it used to be 2 letters. Now, this sounds like a fine protective practice until you recognize that we don't hold cisgender individuals who aren't trans, to the same standard at all. Finding a therapist, especially one comfortable enough with trans care to write these letters, creates an additional barrier to care for a relatively low risk medical intervention. Could you imagine if we required folks to get a therapist sign off before they started chemo or got a tumor removed? This is just one small slice of how trans people have to fight for their own healthcare, well being, and autonomy against a system that tries to deny them such. Cancer is already an incredibly disempowering thing to deal with being in this fight against your own body. Now imagine experiencing that loss of autonomy after you've had to work so hard just to prove that you know who you are. Next slide. So I'm going to get into the screening recommendations after this, but I wanted to highlight this literature review from the American Cancer Society Cancer Journal. I found that across 19 studies, transgender and gender diverse patients had lower rates of cancer screening across all cancer types, not just gendered cancers. Some examples, not only were transmasculine individuals less likely to get pap smears, they were over 10 times more likely to have inadequate pap smears that could not be processed compared to cisgender women. Transgender women were less likely to be screened for breast cancer despite being able to develop breast tissue on estrogen. And on the other side, trans women were also less likely to be screened for prostate cancer than cisgender men, showing this gap that they're falling into where they aren't getting either appropriate screening recommendations. And again, these are some of the examples for the gendered ones, but the literature review also found discrepancies for screening in lung and colorectal cancer. Next slide. So, brief overview, there's much prettier ones out there online, but for trans men in general, unless there has been surgical removal, guidelines for screenings for cervical, uterine, and ovarian cancer should be followed. Again, Even if someone has a hysterectomy, the details of that are going to change what can and can't be screened for if they are, say, if they have, say, an ovarian sparing hysterectomy versus one that isn't. Um, and on the other side, trans women, trans feminine individuals do not need these screenings. There is no procedure for them to get any of the organs listed there. On the flip side, trans men don't have prostates, no way to get them. Trans women, unless they've been surgically removed generally for cancer purposes, uh, or yes, sorry, I skipped ahead to testicular in my mind a little bit. As you might be able to tell by the introduction that I did, I'm a little nervous about presenting this topic in this current climate. So I apologize. But yes, trans women in general will need prostate screenings and testicular screenings unless they have had either standalone orchiectomy or testicular removal for part of bottom surgery. Trans men, again, no way for them to get testes, no need for testicular cancer screening. And breast is the one that is most largely applicable across the gender spectrum. Trans men, trans masculine individuals will need cancer screenings or chest cancer screenings unless total tissue removal is done as part of top surgery. In most totally flat top surgery, this is standard. Um, but there are some cases in which tissue is either intentionally or accidentally left behind. And in those cases, patients will still need to screen for breast cancer. Trans women also do develop breast tissue once they start hormone replacement therapy or gender affirming hormone therapy. And so it's important that once they have developed any amount of breast tissue, that they are given the same screening schedule and recommendations as cisgender women. Next. So some recommendations on how to support trans patients at every step of this journey, right? First off, don't assume sexuality, sexual behaviors, medical history, plans, or priorities. We already talked about how trans people will take different paths depending on their medical plan and medical access. Not every trans person is going to pursue hormones, surgery, etc. Additionally, not every trans person is going to have the same sexual behaviors, the same way that your cisgender patients are not all going to have the same sexual behaviors. So it's important that you are open and honest with your patients and encourage them to be the same with you so that you can get a complete history and a complete picture of your patient, especially when we're talking about sexual history for things like HPV related cancers. Ask what terms a patient prefers for things like body parts, as well as the typical asking name pronouns, though it can be even better to introduce yourself with your name and pronouns, so it takes the onus off of the patient to do so. It can also kind of make someone feel othered if they are only being asked to share their name and pronouns and they recognize no one else is doing that, no one else is being asked to do that. It feels other. But for terms like body parts, for example, some transmasculine individuals may feel more comfortable with terms like chest rather than breasts. Um, educate educate patients about what screenings are currently applicable and how that may change for them, right? So when you're talking with your patient about, say, again, their medical plans, if they say, I'm planning to start estrogen within the next year, okay, so currently you don't need to do breast cancer screenings, but once you do start estrogen, if you do, then here is what you should do for screenings, here is how you do them, etc. Prioritize autonomy and shared decision making. Again, this is a point that I cannot hammer in hard enough. This is important for everyone, but especially for a community that has been consistently disenfranchised and had their autonomy threatened and taken away from them. It is extremely important for support, for helping patients to be able to stick with their care and take care of themselves. Make your space visibly inclusive and follow through. Little things like having pronouns on your intake sheets or having little rainbow flags in your office, having pamphlets that have trans people in them, or even mention gender affirming care can be incredibly helpful, but they don't do anything if the actions of your clinic do not follow through, right? So if you are hanging these rainbow flags everywhere, but not doing anything to make it a more inclusive space for trans people, it's going to be performative. And to that matter, ensure that all clinic staff are aware of a patient's name and pronouns. This can usually be done in the EMR and how to work with trans patients because A patient's visit with you does not start when they meet you. It starts when they meet the receptionist. It starts when they're in the waiting room. It starts when they get their vitals taken by the tech, when they meet the nurse, and then when they meet you. And any step of that process can lead to harm, discomfort, etc. for any patient, but again, specifically focusing on trans patients who we've seen have to deal with this at increased rates. So that's the end of my overall didactic portion. That's the part where I have all the fun notes, and I'm going to be even less put together for the next part. So next slide. Um, so the case studies that I'm going to be taking from are from an Australian study, I'm Not from Another Planet, The Alienating Cancer Care Experiences of Trans and Gender Diverse People. Now, this was a qualitative interview study focused on survivors of cancer of various types, various walks of life, various identities. And I'm going to be narrowing in on a few specific stories that really stood out from this study. Overall, the authors of the study found these 7 themes that came across again and again in these interviews. The first being gendered stereotypes and assumptions, which again is not something that is unique to trans people, right? When we think about things like uterine and ovarian cancer, there sometimes is this focus on fertility over preservation of a woman's life, right? And not prioritizing what the patient's needs are there. And we see that again with trans patients. Negation of identity, we talked about how overly focusing on someone's trans identity can be ostracizing and awkward and harmful, but completely ignoring someone's trans identity can have a very similar effect. Dismissed concerns, patients want to be heard, want to be taken seriously. Invisibility in the system, this doesn't just mean physically in clinics, but also in systems, in insurance, in forms, etc. That this invisibility can cause not only sorts of emotional distress, but also hangups in ability to get care and get care approved. Alienation in waiting rooms and support groups. We talked about if you are a man and everyone sees a man, you're not going to feel great sitting in a women's clinic waiting, right? And uniquely gendered bodies and interactions. For some trans people, they are the first one that a doctor has seen, and the doctor doesn't always know how to deal with them, how to treat them. They are the exception to the, oh, the doctor has seen everything, right? And so that's kind of what we're trying to get ahead of with this sort of education, because we don't want any patient to feel like an anomaly. The final theme that was found in the study was the only positive one, which was affirming experiences. And again, we're going to show examples of all of these in the next few case studies, but affirming experiences can be a silver lining to cancer care, where not only is it important that we make sure that patients are overall having a positive and affirming experience, but that cancer care can even be a part of gender affirming care. Next slide. So, right off the bat, we have Adam, who's a trans man with BRCA gene mutation who had a prophylactic bilateral oophorectomy. Again, this part I don't have as strong notes for. I've, read these cases and I know them very well, but I want this to be more of an off-the-cuff discussion, and we'll have Q&A at the end, but folks are welcome to put thoughts, reactions, etc. in the chat, use the react buttons, etc. Now, Adam's story right off the gate, right out of the gate, encompasses a lot of those themes we just saw, right? He talks about how because the staff is used to working with women, they didn't know how to relate to him. He was constantly pushed this idea that, oh, this could be hereditary, this could affect your ability to have children. Adam was in his 40s. Even if he wanted to have kids, even if he wasn't trans, and trans people can want to have kids, he was past the point that he was considering that. That was not the life stage he was at, but it kept being pushed to him. After his operation, he was put on a ward with 3 women. And he said that he was not comfortable with that. He was not going to stay in a women's ward. And the nurse told him, "You were born a woman. You will behave like a woman." The security guard said to him, "Women do not behave like you," which is kind of this conflicting narrative where Adam still somehow didn't fit either way, right? Adam canceled all his post-operative appointments after that and never went back, not only for any cancer-related care, any post-operative checkups, but he said that he would never go near a doctor again. He would not dare. It does not matter if it's going to kill him. He also mentioned that the fact that he identified as male, that he was trans, presented as a man, etc., none of that was acknowledged or respected because he was there for treatment related to female reproductive organs. It got to the point that he was almost suicidal because of the psychological degradation and disrespect. Now, this one is a heavy hitter, for sure, but it also so well emphasizes those themes we talked about and how we can't make patients priorities for them, and how the way that we treat patients in our clinic, in our field, in our outreach, etc., it doesn't just impact how they view us. It impacts their trust in the entire medical system. Can you imagine being so disrespected by a healthcare provider or a healthcare team that you would sooner die than go back to a doctor? Next slide. So next up, Rose is a trans woman who had prostate cancer. So again, on the side, a traditionally male-dominated cancer field. And she said that her team had no bedside manner for her as a woman. She went to an erectile dysfunction specialist with her girlfriend, and he asked, "Do you actually want to rehabilitate your penis?" Imagine if something was broken on your body, like your arm, and someone said, "Do you actually want to fix it?" There was this assumption that since she was a trans woman, she must hate her penis and want to chop it off, and that's just not the case. This is an example of something called dysphoria, or rather, lack thereof, being the term for incongruence between someone's view of themselves, their gender identity, etc., versus their physical sense of being. And just like with medical care, trans people have different experiences with dysphoria. Some people, some trans women may genuinely be very uncomfortable with having a penis, or like Rose, they may be completely indifferent or positive to it. It's part of their body. There's also a framework looking at gender that focuses more on gender euphoria, which is the positive view of gender rather than focusing on something as suffering, which is a very good framework to look at things through, but that's a bit of an aside. Rose also experienced being refused treatment by two different doctors in 1 year. One of the doctors told her outright, "I do not treat your kind. I do not know anything about you." And this was not for anything gender related. This was her trying to get a colonoscopy. Again, she said, "My blood's red. I've got the same organs as everyone else. I'm not from another planet." Next slide. So Marlena, another trans woman, she had bowel cancer, and her identity was negated immediately. As soon as she met the chemo oncologist, he said to her, "I know you're trans. We don't need to discuss that." Now, that didn't lead to her being treated like any cis woman with bowel cancer. It led to her being treated like a man. And she thought it was a bit odd. And then later, when he had the nurse come in to make her a follow-up appointment, the doctor repeatedly called her he needs an appointment, he needs a follow-up, etc., even in times when it would have been appropriate to use her name, that he repeatedly just called her he. Later, Marlena would have problems with dilating. So Marlena was a post-operative trans woman, and that was something that was very important to her identity as a trans woman, that she had been able to get vaginoplasty, which had to be maintained with dilating at the time. And she expressed this to her team from the very beginning and throughout her journey, that this had been a journey in and of itself, right? For her to discover herself and then be able to get her vaginoplasty. And after she was treated for bowel cancer, she was no longer able to dilate. She was no longer able to experience penetration, etc., to use her vagina that she, again, had gone through significant surgery and turmoil for in the first place. And she told the oncologist, I'm having problems down there. I'm closed up. You've welded me shut. And
Did the
We
audio just
lost. No, we
okay.
lost the presenter.
My Zoom crashed. I don't know what happened. I'm back. I'm so
I was
sorry about that. I guess Zoom did not like me talking about vaginoplasty. Um, but the more notable thing was that the doctor said, I saved your life. What more do you want? Marlena said, how do you respond to that? Okay, on one hand, you have a point, but you had no concern or care for me as a person. Your only concern was that tiny little tumor. Whatever happened after that, bugger, I do not care. And that line there, that tiny little tumor, really emphasizes, for anyone who does cancer related work, that tends to be our focus, right? We zero in on that one thing. But in the context of the larger person, for Marlena, it meant giving up a major aspect of herself and her identity and her body that she had worked for, that she hadn't even thought was on the table to lose, and then got absolutely no empathy from her medical team. Next slide. Also, I will say if anyone puts stuff in, okay, I can't see the chat. I was unsure if I lost the chat when I lost the Zoom. Um, so Paul had a bit of a different story. He is a trans man, but actually had pediatric liver cancer and then had to have follow-ups throughout his life. And so the care team he grew up with knew him as a girl, knew him as a woman, and he never felt comfortable coming out to that initial care team because he just didn't know how they would react. They'd known him his whole life. When he eventually grew up, switched medical teams, etc., and presented as a man to all of these clinics, he also didn't have his legal information changed. And when he would go to try to get care, try to check in, etc., his legal information would cause confusion because people would look at him and see a guy, see that he had just said he was by this name. They would look down at the paperwork, see F, see his dead name, and they would ask, are you sure you are this person? Which, is emblematic of both the administrative struggles of being a trans person, but also of having to prove who you are over and over and over again, even if you know it, and even if the people around you don't have to prove themselves in the same way. Paul also mentioned that after he came out, he could not bring himself to go get any gynecological exams because he didn't want to stick out. He didn't want to be uncomfortable. He didn't want to make other people uncomfortable. And so he just simply never went. Next slide. Now, Hunter is a genderqueer individual who had multiple skin cancers and small lymphocytic leukemia. So obviously that meant pretty frequent and ongoing checkups, check-ins, etc., with a rotating public health system. So they generally weren't seeing the same provider every time. And for Hunter, the anxiety that came with each visit wasn't about if they were going to find a new cancer, if there was going to be a new melanoma that would have to be taken off. It was going to be how the provider treated them. They likened it to buying milk, where if you buy milk, you know you're getting milk. If you go to a healthcare clinic, you should know that you're going to be able to get health and care, and that includes respect. They said it's not the anxiety that they'll find a cancer or they'll have to cut, it's the anxiety of will you be nice? Like imagine being so afraid that a medical provider is going to mistreat you, that you're less afraid that they're going to find cancer when they found cancer before, that they would just rather the provider be nice to them. Next slide. Now, this is the last of the studies, or of the interviews from the study that we're going to look at. There's a lot of wonderful quotes from a lot of wonderful people in the study, and I do have a citation slide where you can go look at the study for yourself. But Sam was a non-binary individual who had an amazing experience with their surgeon. Right away, the surgeon was accepting and prioritized Sam's autonomy, did not make any decisions for them, And that helped Sam to feel more comfortable and say to the doctor, I'm non-binary. I've always felt like I was in the wrong body. It's really important. I don't want them back. I don't want my breasts back. I don't want reconstruction. I want a flat chest. And she was really amazing all along the way. She was really accepting. And this is not a unique tale. I mentioned briefly that cancer care can be part of gender affirming care, things like chemotherapy leading to menstrual cessation, for one. And this is one of the more common ones that I've seen and heard anecdotally of transmasculine individuals being able to get mastectomies as part of breast cancer treatment or prevention. I knew someone who their mother had a BRCA gene mutation and they were getting tested, and they genuinely hoped that it would be positive so that they could get their hysterectomy and top surgery covered. This was before gender affirming care was more widely covered by insurances. Um, and, you know, that's not to say that I think anyone out there is wanting to get cancer, but I feel like that little anecdote as well, again, shows the importance to so many trans people of agency in their own bodies, being able to make the decisions that we need to make to feel like ourselves. And again, with cancer, already an incredibly disempowering thing to deal with, we want to make sure that we're making that journey as smooth as possible every step of the way. Next slide. So I have a couple of resources here. The one on the left is queeringcancer.ca. This is a Canadian website. Unfortunately, many sites maintained by the US government and agencies have been taken down. Projects meant to support trans and marginalized communities have been shut down and defunded. And what's left is in an unstable and precarious state where I can't confidently recommend them because they might be gone by the time you go look for them. So queeringcancer.ca, again, it's a pretty simple URL, so I didn't put a QR code. But on the other side, the American Cancer Society has a fantastic flyer pamphlet thing on trans screening recommendations as part of their professional resource library. That QR code will take you directly to the download. So if you do it, it will like immediately start downloading something. Don't panic. It's just from the American Cancer Society. But if you want to find it elsewhere, it's just in the professional resource library. But especially right now, if there are any resources or information that you find that you like regarding any minority health, regarding any health equity topics, highly recommend downloading them and keeping physical printed copies as well so that you can have ongoing access no matter what happens. Next slide. So that's what I've got for y'all. Again, I am humbled to have had the opportunity to come speak with y'all today, even if it's in a bit of an unusual fashion. I hope that y'all were able to get something out of this presentation that you can take back to your clinics, your patients, etc. And yeah, if anyone has any questions.
Thank you so much for this presentation. It was amazing. This is my second time going through it, and I have more questions. But I'll see in the chat first if anybody else.
We don't have any questions or comments in the chat.
Okay, please feel free to unmute or type your question out. Oh, Janet, do you want to unmute?
Yes, I just would like to thank you for the great presentation. I have been taking a course before regarding the transgender LGBTQ plus community, and every day I really learn more thorough information about it, and at the same time learning more of the bias and the inequities in the system, and really even myself as a person that have coming from the Hispanic community, having met them sometimes, the doctors behave in a different way. Like we have to, there are barriers, there are challenges, and I can imagine the transgender community having experiencing more bias going to the doctor, and this is totally unfair, and this is something that we should continue addressing, even for the doctors. They really want their patients to be in good health.
Yeah, thank you so much. I absolutely agree on all fronts. And, you know, minority health, health equity, they are not exclusive topics. The identities that people hold are not exclusive. There is overlap. And, again, a lot of us in this field, from what I saw from the chat, in public health, we know the importance of treating people and not like their conditions, not like these very tiny aspects about them. And so I really, really appreciate y'all coming out to any and all of the Echo presentations, but especially this one. I also know that it wasn't the original topic that this was going to be. Um, but, thank you, Janet, for your allyship to the community and your continued dedication to learning.
If anybody else has something they'd like to say, please feel free to unmute, to type it in the chat. I had a question about Adam's story. I wanted to get your professional opinion. What could we do as like public health professionals to regain Adam's trust, if there is a possibility for that?
Yeah, so I think that that is can be a very individual question, right? So in a case as severe as that, where someone's saying they would rather die than go back to get medical care, right? Public health outreach can be a really key part of that because oftentimes it is a way for patients to get screenings, get basic care without having the burden of going into a clinic and kind of reliving that trauma, reliving that fear, right? And again, a lot of marginalized communities have both individualized and systemic trauma from the medical system. We think about the history of things like Tuskegee, of reproductive coercion, the AIDS crisis, et cetera. And so whether someone has that individual trauma like Adam has, or they know that their community has had it, really doing what we can to demedicalize these processes. Again, making spaces as inclusive as possible, making sure that your entire team is on board with treating people with respect, which feels like it should be an obvious thing. Um, but again, that first step of really how do we get someone back in the door? Again, I think a lot of that can come down to outreach and also acknowledging and recognizing those harms. I've met a lot of providers who really dismiss the impact of medical trauma and who really act like patients just need to get over it because they need to get care. It sucks that they had an experience with, this provider, but we are not that provider. And on the one hand, yes, you are not that provider, but by immediately dismissing their concerns and their experiences, you're starting to prove to them that you're not any different from that provider. Does that help? Okay, great.
Yeah, it helps. I couldn't find the unmute button. Yeah, and that helped. Thank you. Um, Let me just want to check the chat. Yes, Donna said it was a great presentation, very insightful.
I
So I
see
was wondering,
Evelyn. Oh, sorry.
no,
I
what did
just
you say?
saw Evelyn's comment about how parallels to menopausal cis women are treated when it comes to hormone care. Hormone replacement therapy is used for both menopausal cis women and trans women. It's the same medications. And a lot of people, they hear phrases like hormone therapy and they get very prickly, not realizing that it's something that cis people use too, including men with low testosterone. They also use hormone replacement therapy. And gender affirming care, as a result, is not just something that trans people access, right? Like we mentioned those surgeries, right? But cis women getting breast implants, who, again, we don't ask for therapy letters for that. Cis men getting testosterone therapy, getting hair transplants, etc. These are all forms of gender affirming care that are afforded to cis people without a second thought and fought tooth and nail for trans people to not be able to get. And mind you, again, we're like 1% of the population.
Okay, I'm gonna go to the NJ seat information, but if you have any questions, you can put it in the chat. This also will be uploaded to the Mighty Network, so if you come up with questions later, you can put it there, and I'll reach out to the presenter to get more information, to answer the questions. So some NJC information, they offer free cancer screenings all over the 21 counties of New Jersey, and the information will be posted in the chat, the number, the website as well. And thank you for attending today's session. So please let us know how we did. The link will be in the chat. You can use this QR code as well to fill out the evaluation form. And then, as I said before, all of the materials and resources, the resources that we went over, the 2 links, will also be posted on the Mighty Networks, as well as the citation, and the recording, the PDF of the presentation. It'll all be there. And then join us next month for a session on breast cancer survivorship. Thank you all for attending today.
Thank you all so much for having me.